bioenergetics is the study of energy in living organisms, which is metabolism in some, where you are familiar with the building up and the breaking down and the energetic expense, or the molecules that have to get broken apart to pay for that work, if you will. So my focus in metabolism, which more and more, I guess to define that a little deeper, is I study metabolic health. And I define that based on the efficacy of the hormone insulin. And someone may think that's a strange step to take. How do we go from metabolic health to the hormone insulin? It's because insulin is the gatekeeper to all reactions that I care about as a scientist who studies muscle and neurons and fat cells. That's the primary tissues of interest for my lab. Insulin has a thematic effect throughout the body, which is it tells cells of the body what to do with the energy that it has. And in that role, it has a powerful influence, potentially influencing whole body metabolic rate, for example, getting back to bioenergetics and measuring metabolic rate. So my focus as a metabolic scientist is really studying the effects of insulin and the consequences of having too much insulin, to be really precise. Yeah, my research, with the big theme being better understanding insulin and the pathogenicity of living a life where insulin levels are too high too often. An average day will be a mix. Insofar as I am, yes, both research scientist and professor, I will have a mix of teaching a class. And this semester, it just happens to be my teaching assignment is a class called pathophysiology. So pathophysiology is a course that nursing students will take, and a lot of pre-med students take it. Just if you'll allow me a brief aside, it's been a very gratifying class to teach because it has helped hone and perfect my view of the relevance of insulin resistance in chronic diseases of virtually every tissue. Whether we're talking about heart problems or liver problems or brain problems or reproductive problems, it's been a fun exercise for me over the years as being a teaching professor to, just as an act of personal curiosity, look to determine the influence of insulin resistance in those and more problems. But then other than the classroom, of course, I have a considerable interest in what goes on in my laboratory here on campus, where we have multiple projects going on. For example, today we have a lab meeting to discuss a uric acid project that we're doing with Dr. Rick Johnson at Colorado. And just to shed a brief moment of light on that, we're trying to determine the degree to which ketones are sufficient to offset the inflammation that is turned on in response to uric acid. So what happens if uric acid levels are up, but also ketone levels are up within a body? So that's one of a handful of experimental designs and projects that we have working on. And just so that the audience appreciates why I would even devote my career to this, insulin resistance affects up to 88% of all adults within the United States, based on recent data. This is the most common health problem. And if that were all, and it was a health problem that was benign, then who would care? But the fact that it is not only the most common health problem, but also contributes to every non-communicable chronic disease, it means it's also, not only is it very prevalent, but also very relevant. So how does it start? Firstly, let me just provide my own very brief definition of what insulin resistance is. And I will invoke a metaphor of a coin. That imagine this coin that I'm holding is insulin resistance. On one side of the coin is the phenomenon that you just described, which is insulin isn't working as well as it used to. At some cells, I will add that as a provision here. So some of the cells of the body, indeed big ones and dominant ones like muscle cells and fat cells, aren't responding to insulin as well as they used to. Now, however, some cells are responding well to insulin, and that becomes a problem when we flip the coin over, because the other side of the coin that we call insulin resistance is an obligatory hyperinsulinemia, or chronically elevated insulin. And that's a good place to start because of the handful of causes of insulin resistance. I firmly believe that chronically elevated insulin is the most relevant of the causes. In other words, if a person is living a lifestyle which is chronically keeping their insulin at an elevated state, they become progressively more and more resistant to that insulin. At least some of the cells of the body do. And this then is the insulin resistance in that coin metaphor. So chronically elevated insulin is a key cause. Now, of course, as the body becomes more resistant to insulin, it needs more insulin in order to get the same signal that once upon a time was realized with a more modest amount of insulin. And thus, we start to see this very vicious cycle where, yes, on one hand, too much insulin is driving insulin resistance, but a failure of the body to respond to the insulin is in turn promoting a greater need for insulin. And so we end up with this scenario in which hyperinsulinemia is both cause and consequence of insulin resistance. If a person eats pure fat, there is no insulin spike at all. The body, the beta cells of the pancreas don't respond to dietary fat. When someone eats pure protein, there can be a modest effect, but it sort of depends on the individual. For example, type 2 diabetics may have a higher response to protein than a non-diabetic. In fact, most certainly does. But generally, it's little to no effect. When someone eats pure carbohydrate, there is a substantial effect, where even in an insulin-sensitive person, insulin will easily spike 10 times over normal, over fasting levels, and take up to 3 hours before it comes back down to normal. If we were to look at that same response to pure carbohydrate in an insulin-resistant person, it could go up twice as high as that, so up to 20 times higher than normal, and stay elevated for up to 5 hours. Now,
in an attempt to bring down the blood sugar.
That's right. Insulin's just having to work so much harder and stick around so much longer in order to correct the blood sugar, all the while creating havoc throughout the body at the liver cells or the gonads, the ovaries in women or the blood vessels, creating metabolic havoc in the meantime. Now, that phenomenon, that response to carbohydrate, is relevant in and of itself. Uncommon person will eat only 3 meals a day and be insulin sensitive. And so if they eat 3 meals a day with about 4 hours in between each meal, there has probably been some period of time, about an hour or so, before the next meal when insulin has been able to come back down to fasting conditions. So they have most of their day is spent with normal insulin, or at least a decent part of it, of their waking day, a decent part of it. Most people don't eat 3 times a day. Most people eat 6 times a day or so. They will have 3 big meals and then 3 snacks in between. That we call it a snack, but it might actually be as big as the meal itself was, particularly into the evening when most people really start to indulge. And second, most people are eating primarily carbohydrate. Globally, about 70% of all calories consumed are carbohydrates. So we're eating not only most of the greatest insulin spiking macronutrient, but we're eating them every hour and a half or so. So insulin never has time to come down. But the third aspect to this that's still relevant is that the average person is, in fact, insulin resistant. And so there is not even a hint of moment where in every waking moment, insulin levels are elevated. The most relevant is just give your body a break from the hyperinsulinemia. Give it a chance to have insulin come down. And now you can resensitize the body, and your risk of all of these chronic diseases goes away, if not the disease itself disappearing.
And get a good night's sleep.
Absolutely. And that's much easier to do, David, if they go to bed without having hyperglycemia. As much as we always focus on blue light, and I think that matters, I'm not saying it doesn't. What too many people overlook is, what did you eat before you went to bed? And we know very well that if someone goes to bed with hyperglycemia, they will have activated the sympathetic nervous system. Good luck trying to sleep if you are in your fight or flight response mode, where your blood pressure is going to be higher, your heart is beating harder, and your body temperature is going to be elevated. That is a perfect storm to ensure it takes you a long time to fall asleep, and you're going to sleep poorly. And most people will say, I'm a bad sleeper because I just start to feel anxious. Anxiety has nothing to do with it. You've simply activated. That's the consequence.
If you're having a fasting blood sugar once a year, which I think is ridiculous, a snapshot when you should be looking at a video, why not at least ask your doctor to do a fasting insulin at that time as well? A better test would be a glucose tolerance test with insulin measurements each time. And then what is your feeling of the merits of a continuous glucose monitor?
Yeah, I am an enormous advocate. I've looked with some wonder at this debate where many people are very animated in their opposition, and I can't understand that. To me,
I know what the argument is, and it's puzzling. But the biggest argument, as published in the debate, which was an op-ed actually in the Journal of the American Medical Association, was giving people this data is going to make them neurotic. Oh my gosh! Therefore, we shouldn't allow people to buy scales, so they can't. So
That's
they don't have
right.
to know how much they weigh.
Yeah, heaven forbid.
Just a metric that you can use.
Yeah, heaven forbid. Don't let anyone have an at-home blood pressure monitoring device.
Right. The doctor knows best, and we'll check your pressure.
Yeah. And what good is a speedometer on your car? You don't need to know how fast you're going.
Yeah, it's true.
It's crazy. I think that there is. Wouldn't it be wonderful if more people were a little neurotic about what they ate? Perhaps we wouldn't be in the problem we're in. But I think that's a silly premise. I do firmly believe in the democratization of CGMs. I have seen so many people's lives changed, and the power of it is that they change themselves. Once they see what's happening in their body, they don't need someone to be telling them what to do.
Exactly.
It ends up becoming a self-correcting behavior because they look at what happens when they eat these foods that they are told they should, and they see their glucose levels go up to 300 milligrams per deciliter, and it takes 4 hours to come back down. Or they eat something simple like scrambled eggs, and then they see that there's no response whatsoever. For me, allulose got on my radar intellectually when I saw data that suggests that shows that allulose as a rare sugar increases GLP-1. Now, GLP-1 will sound a little familiar to the audience because that is the drug mechanism of the most famous weight loss drugs on the planet right now, in the form of semaglutide, and then in the form of Wegovy is the weight loss version, or Ozempic, which was the earlier lower dose diabetes. Yeah, the anti-diabetic version. Frankly, when it was at the lower levels, when in my PhD work in bioenergetics, it was actually at a lab that was among the first labs ever funded by Johnson & Johnson to study the effects of the incretins. So I have kept my finger on the pulse of this work for almost 20 years at the very, very beginning. So that has left me with a pretty strong appreciation for the drug and increasingly a wariness, to be frank, where at its original lower dose, and I will mention some of those effects because I think it becomes a little relevant with allulose. I could look at it and give it a passing grade. As much as I am very reluctant to embrace drugs as a therapy for metabolic health. Indeed, I am. But even still, I could look at it and say, all right, the benefits may be worth the negative consequences, because every drug we take is a matter of balancing consequences. Are the ones we want worth the ones we don't want? So again, to answer the question succinctly, I was interested in allulose when I saw that it had a substantial effect at increasing GLP-1. Now, so what? Well, there are benefits to increasing GLP-1, one of which is to delay gastric emptying, so it helps you feel a little more full. So if someone were to take allulose before their biggest meal of the day, for example, it's very, very likely that they will control their appetite a little better during that meal. Or in the evening when they're at their weakest and they typically indulge more, perhaps a little allulose is going to be sufficient to take the edge off those cravings and help them just feel full a little better. So it delays gastric emptying. It slows the rate at which the food is moving and helps you feel full longer. Another benefit of GLP-1 activation that we can see with allulose is that it inhibits the hormone glucagon. And as much as we've been talking about insulin, glucagon is insulin's opposite, with a few different metabolic pathways or metabolic processes, most especially being blood glucose levels. Whereas insulin wants to lower blood glucose levels, glucagon wants to increase blood glucose levels. And so if GLP-1 is increased and it's inhibiting glucagon, we can see that that's another mechanism whereby allulose may be helping correct blood glucose. And this, I suspect, is one of the main reasons why the evidence that we see, a lot of it's anecdotal at the moment, of people with type 1 diabetes who take an allulose product like RX sugar, they will have a significantly easier time controlling their blood glucose levels, even after they eat something that is starchy or sugary. And it's probably due to the inhibition of glucagon, which is chronically elevated in states of diabetes, type 1 or type 2. So these two phenomenon the delayed gastric emptying and the reduced glucagon, I believe, are mechanisms that help control blood sugar because it's controlling the amount of glucose coming into the blood, which is helping insulin be a little lower. But also, there's substantial evidence to suggest that allulose helps on the backside as well, which is the glucose clearance or removing the glucose from the blood. So not only controlling the amount coming in, but also the amount going out, namely increasing it by activating an enzyme called AMPK. And everyone by now has heard of mTOR, and that's a topic for another time. But mTOR is this now famous protein that wants to build things up. AMPK wants to break things down, including accelerating the rate at which we're burning through glucose, just to start increasing the catabolic side of the metabolic equation, breaking things down for the production of energy. So collectively, this really does become a pretty metabolically favorable milieu where the GLP-1 increase is delaying gastric emptying, and it is affecting glucagon levels, helping reduce the amount of glucose coming into the blood. And then the allulose is directly increasing AMPK at tissues like the muscle, which is accelerating the rate at which we're pulling the glucose out and burning it for energy. Most people don't appreciate the origins of uric acid, where we have this very, not your audience, but average individual, if they know anything about uric acid and gout, they're going to repeat the same old line, which is avoid meat, and beer. Maybe if they're thinking a little further, they may invoke beer as well. And those may, especially beer, I would say much less meat. While that may be a source of uric acid, by far the greater source is fructose metabolism. And again, a topic you're more familiar with than me. My answer to the question then is simply the degree to which allulose can be used as a replacement for fructose-containing sugar is a direct swap will result in an immediate reduction in uric acid production, and I've seen this as well. And time will test this out with more peer-reviewed randomized trials. But I strongly suspect as those trials begin to come out, we will see as allulose is used to swap out sugar and other fructose-containing sweets. We will produce less uric acid and gout symptoms will improve. It seems inevitable. We have found in virtually every experimental model, if you can turn on AMPK, you will improve insulin sensitivity. Now, there are other ways I could answer this, but that becomes a pretty convenient answer because we've already discussed it. So AMPK will increase the rate at which a cell is using energy, using nutrients to burn nutrients for the sake of producing energy for the cell to work. Exercise activates AMPK, fasting activates AMPK. Because one of AMPK's effects is to use more glucose, you want to make the cell more insulin sensitive. For example, a muscle cell or a fat cell is going to have a hard time using glucose if it's not insulin sensitive because it needs insulin in order to get the glucose to be pulled in, except for exercise in the case of muscle. But even then, even in the case of exercise, where when the muscle's exercising, it doesn't need insulin for glucose uptake, but it still needs AMPK. It just has a different way of activating it. So one way or another, we have to go through AMPK in order to open up these insulin-dependent glucose doors and pull in the glucose. So in that sense, AMPK once again becomes a primary solution to improving insulin sensitivity because it will directly activate that pathway.
Yeah, and that does feed back to our discussion moments ago about uric acid. We know that AMP has to be metabolized, and generally we consider the fact that, well, that's what AMP kinase is all about, but it turns out that AMPK has an evil twin, which is AMP deaminase. And what AMP deaminase does is really pretty much the opposite of its twin, AMP kinase, and that is it fosters increasing blood sugar, increasing gluconeogenesis, the production of blood sugar, the lack of our ability to utilize fat, and even to some degree increases mitochondrial dysfunction so that we don't burn as much energy. And guess what? The lever is pulled by high elevation of uric acid. Uric acid is one of the arbiters of determining which way we go. AMP kinase on the good hand, and AMP deaminase on the bad side.
Fatty liver disease has two origins. I mean, the ultimate problem being it just has too much fat. Now that sounds more benign than it is, because having a fatty liver is just one small step away from it starting to get inflamed, and then scarred. And it really is the gateway problem to further, much more catastrophic liver problems. So we want to catch it at the fatty liver state because we can still turn it around, and we can turn it around quickly. Now, where does the fat come from? There are two sources for that fat. One source is insulin-resistant fat cells, where the fat cells that are upstream from the viscera, as they start leaking their fats in a state of high insulin, then the liver will readily pull that in and store it. So that's one source. And in that case, if allulose can improve by activating AMPK, the insulin sensitivity of the fat cell, then that fat won't be leaking out of the fat cell in a state of high insulin. It's okay for a fat cell to leak fat in a state of low insulin, because then the liver will just burn it. But if the liver is seeing a lot of fat and insulin is elevated, it cannot burn it. Fat burning will be stopped. Fat oxidation, it will have to store it. It turns it into triglycerides, and now we have fatty liver disease. But then second, we come back to fructose, because the other most common form of the liver accumulating fat, or the most common mechanism, is it making its own fat. This process called lipogenesis. In fructose, I'll never forget a manuscript I read probably 20 years ago that described fructose, one of its many ways of describing it, as the most lipogenic molecule in the body. So the liver will so readily take that fructose and turn it into fat very, very easily. And so that becomes a direct contributor where if someone's eating fructose heavy sweeteners or sugar, or in any other form of it, then that fructose is directly contributing to turning into fat within the liver. But if that fructose rich sugar has been replaced with a rare sugar like allulose, then you are no longer getting it. And rather than having the building block for fat, in contrast, you're activating AMPK in the liver, which will promote fat oxidation, or the burning of the fat. So then you begin literally resolving the problem rather than contributing to it. We know that type 2 diabetes, or just insulin resistance, is the leading risk factor for heart disease. So any intervention you're embracing that is improving those aspects of metabolic health is reducing cardiovascular risk.
People would want to listen to what you just said, that insulin resistance is really the leading contributor to heart disease. And how many years have we been saying, oh no, your cholesterol level is elevated?
I know.
So
in fact, David, did you see the paper that was just published? Was it maybe New England Journal of Medicine, where they looked at the 5 leading risk factors of heart disease contribution, and LDL was the absolute lowest of all of them, and having a history of type 2 diabetes was not only the highest, but nothing else was even close.
Right.
It was multiples higher than every other risk factor. There's no question that the current view of metabolic health, which is a glucose-centric paradigm, all with the understanding of eat a lot of carbs and eat them often, it is a wonderful way to sell medications.
Yeah. And it works for everybody. Everybody gets a hand in the fructose sweetened pie.
My lab's published work, which is building on the work of many other much more prominent dementia, Alzheimer's focused scientists than I am. I'm a mitochondria guy, but it was in there that we made our contribution, where we found that one, that the brain with dementia has a perfectly preserved, at the level of its genetic expression, ability to use ketones for a fuel, whereas almost every gene involved in glucose metabolism was significantly compromised in brains in the hippocampus, the memory and learning center of people with Alzheimer's disease. So there's a direct ability of the ketone to fuel the brain.